Good evening, everyone, and welcome to tonight's clinical webcast, Advancing Keratoconus Care, Surgical Planning, and Clinical Insights with CTAK. For all those attending, if you'd like to ask a question during the webinar, you can use the chat box on your screen and we'll answer as many questions as we can at the end of the session. We're very excited to have both Dr. Greenstein and Dr. Gelles here with us this evening. Dr. Gelles is the director of the Specialty Contact Lens Division of the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus in Teaneck, New Jersey, an assistant clinical professor at Rutgers, New Jersey Medical School in the Department of Ophthalmology and Visual Science, and an adjunct clinical professor at State University of New York College of Optometry, Illinois College of Optometry, and New England College of Optometry. Dr. Greenstein is a graduate of Harvard Medical School's Cornea, Refractive, and External Disease Fellowship at Massachusetts Eye and Ear Infirmary. He is currently the medical director of the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus. He has authored articles and book chapters on corneal cross-linking and is a co-inventor of Corneal Tissue Addition Keratoplasty. Dr. Greenstein is board certified in ophthalmology and refractive surgery and is a clinical assistant professor at Rutgers, New Jersey Medical School. He is a member of several ophthalmology societies and serves as the ophthalmologist for the New York Jets football team. Without further delay, Dr. Greenstein and Dr. Gelles, the floor is yours.
Awesome. Well, thank you so much for the kind introduction, and thank you so much for having us back. Topic that we're going to go through tonight is very near and dear to us, and let's jump into it. Advancing keratoconus care and surgical planning and clinical insights with CTAK. So what we want to talk about tonight really focuses around the modern management of keratoconus. We like to refer to this as keratoconus 1, 2, 3, and this is really a comprehensive view of keratoconus management. First thing that we want to look at is stabilizing a keratoconic cornea, and we do that with corneal collagen cross-linking. The second step in keratoconus 1, 2, 3 is correcting the curvature or the topography of these keratoconic corneas so that we can have better correctability for uncorrected and spectacle corrected visual acuity. And then our last portion is taking care of vision, whether that is surgical or non-surgical with contact lenses. And tonight, CTAK is really going to focus on that step 2 stage. So we're looking at correcting the curvature and the tomography so that we can get those improvements in the comprehensive visual management of the patient. Many individuals, if you just ask them the simple question of, how is your quality of life when you're not wearing your contact lenses? Almost all of them will say, I can't wear my glasses, I struggle, I can't have functional vision when I'm not wearing my lenses. Keratoconus 1, 2, 3 as a concept really looks at trying to maximize the vision in all of those 3 situations: uncorrected, spectacle corrected, and contact lens corrected. So let's jump into CTAK. There we go. So CTAK stands for Corneal Tissue Addition for Keratoplasty. Essentially what this procedure is it's using visual axis sparing lamellar corneal inlays. These inlays can be fully customized to the patient, looking at multiple thicknesses, widths, optic zones, looking at different lengths of the tissue, and just really customizing it to that individual's exact tomography and being able to maximize that benefit. The current tomography that we favor for this is the Pentacam tomographer. But when we look at this, what we're really looking for is this ability to make these dramatic topographical changes and the corresponding effect that we'll get with visual acuity. So the way that this works is these pieces of tissue are produced by corneagen. This is tissue that is derived from the stromal cap of DMEK and DSEK preparation. This tissue is then put on the femtosecond laser, cut to specification, and then goes through a gamma irradiation sterilization process, which essentially eliminates the host antigens and then makes the tissue shelf stable for up to 2 years. The laser that they use to prepare this tissue is the Zemer Z8 femtosecond laser. And, often the question comes, is there, an advantage to using a laser cut tissue and using this gamma irradiated tissue? And what we can see here is a manually prepared tissue on the left at a 1-year follow-up. And on the right, you can see the CTAK tissue, and you can see just the level of clarity there and the precision to that, and just how well that incorporates into the cornea. When we look at candidates for CTAK, who is the right individual for a CTAK procedure? What we are looking for are patients with irregular astigmatism. We're looking for Kmaxes between 50 and 80 diopters and best corrected visual acuity worse than 20/20, looking for kind of 20/25 and above. When we look at the ideal placement of their cone, we're looking for cones that are kind of inside the central 6 millimeters of the optic zone. So within that 3 millimeters from the center of the pupil. We want to avoid anything where we have scarring in the visual axis because they're not going to get the main benefit of CTAK. Those patients may be better served by DALK or traditional penetrating keratoplasty. The other pearl in this is to be a little bit careful with ectasia. One of the clinical pearls that Dr. Greenstein will go over later is in patients who have had or who have a post-refractive corneal ectasia post-LASIK. Those individuals, we want to make sure that we implant this tissue deep enough that you're under the flap and don't end up in the flap interface. That being said, let's go over 2 real quick cases. So this is kind of your ideal patient. You can see irregular astigmatism, so you can see that asymmetry from top to bottom. That is really key for this procedure. You want to have a Kmax within that 50 to 80 diopters, so this patient falls perfectly in that. And when we look at the visual acuity here, you can see this individual actually has pretty decent uncorrected visual acuity at 20/60, but you can see their best corrected spectacle visual acuity is 20/30. So this individual could benefit from having CTAK. By making the cornea more symmetric, we then make it more correctable, and thus get that improvement in the best corrected spectacle visual acuity. Now, in contrast to that, let's go over a case that is not an ideal candidate for this. So let's take a look at this. This is nice, classic bow tie astigmatism. This is a patient who, though they have a thinner than average cornea, don't really have a Kmax in that, greater than that 50 diopter area. And you can see that this is very symmetric bow tie astigmatism. In this case, you can see, though their uncorrected visual acuity is similar to the above case, you can see that their best corrected spectacle is 20/20. This individual would likely be better served with, other forms of treatment such as, topography guided PRK or just PRK in general. And being able to kind of clean this up a little. So this patient is not the ideal candidate for CTAK. What we want to go through here is also to highlight that the cone in this cornea is within that 6 millimeter optic zone. This is kind of the ideal placement for this. Other kind of topography patterns that work well for this are kind of all of these that you see here. We've all seen the variety of different types of keratoconus and the different types of patterns that may present, but the ideal patient criteria is somebody who has the cone within that central 6 millimeters. Patients who are not good candidates for this, these are kind of the patterns that you may see for this. This is when Kmax and the thinnest point, the thinnest pachymetry are outside of the 8 millimeter optic zone. This would include, pellucid pattern keratoconus, pellucid marginal degeneration, and pellucid pattern ectasia. These sorts of cases do not have, are not ideal candidates for this procedure. Now, we did a prospective clinical trial here at the Cornea Laser Eye Institute, and we're fortunate enough to have our results featured on the cover of JCRS. And what we looked at was 21 eyes of 18 patients who underwent CTAK. And what we found was that in the uncorrected distance visual acuity, patients improved by an average of 6 lines. So going from about in between 2200 and 2300 down to about 2080. So a very large improvement. And what you can see here in the distribution off to the right is that nobody got worse by 2 lines or more. And you can see the majority of individuals actually improved by greater than 6 lines. So this is a very, a very strong performance for this procedure. The other thing that we saw was not only does it improve their uncorrected visual acuity, it does correct their spectacle or their distance corrected visual acuity. So what you'll see is an improvement of about 3 lines or more. And when you look at their distribution here, you can see again we had tremendous gains all the way across the participants here. The other thing that we see with this is that we move our spherical equivalent more towards plano in these cases. So again, you can see that even at week 1, they get a tremendous impact from this procedure. The cool thing about this procedure is they even get like a wow factor immediately after and the day after. But definitely the 1 week mark, they're seeing very good results here. The next one is kind of looking at the topography descriptors, right? When we look at, the mean K, we saw about 8.5 diopters of flattening. The area of maximum keratometry, we had about 7 diopters of flattening. But the thing that we really, are looking at the most here, the areas of maximum flattening, right? So when we're looking at this, we're seeing about 16 diopters on average of flattening at the 6-month mark. But the thing that is way more important than all of that is that when we stratify this by subject, we can see just how custom we can make this procedure for the individual, right? You can see if we needed, a very small amount of flattening, we were able to create a very small amount of flattening. If we made a very large amount of flattening, we could create a very large amount of flattening. So you can see that we were able to control this by customizing the thickness, the arc length, the diameters, all of these things to make a really, really impactful outcome for the individual. And there's just some examples here. You can see on the top, this is a severe level of keratoconus, and we were able to create an inlay that was able to flatten that cornea 24 diopters. In the center, you can see kind of a moderate keratoconus, and we were able to flatten them by about 10. And then in the individual at the bottom, mild keratoconus, and only needed to flatten them by about 4. But you can see how the postoperative outcomes, you're getting these really great correctable topographies off of that. And that's why we're getting this visual acuity improvement by ameliorating that irregularity. So from here, I'm going to go ahead and pass it off to Dr. Greenstein, who will go over the specifics of the procedure planning.
Okay, very good. So I think at the end, Dr. Gelles really was highlighting some of the reason that CTAK can be so effective in our keratoconus patients, which really is its customizability. So what we always say is it's not just about how much you can flatten a patient, but it's about getting the right amount of flattening for each patient to create a more regular shape for their cornea. And we like to call the process CTAK to get to those CTAK results, the CTAK ecosystem. And that ecosystem starts from getting a corneal topography on your Pentacam, then with being able to upload that topography through the CTAK uploader to CorneaGen. The surgical plan will be provided for each surgeon to approve, and then the inlay will be cut to those specifications on the femtosecond laser, the Z8 laser from Zemer. That exact tissue specifications will be provided for each surgeon in a shelf-stable form. So it comes in a box that actually is shelf-stable for 2 years. And then finally, you get a surgical plan for placement so that you can place these inlays in proper position to get reproducible results. So tonight I want to kind of walk through that process from start to finish and then end with some interesting CTAK cases to sort of hopefully highlight the use of CTAK across both some of the more regular cases that we use CTAK for, and then some of the places where we found CTAK to be effective as well. So it really all starts with your corneal topography. And on the Pentacam, there is CTAK uploading software. So if you get the CTAK uploader, you can go to the external software button at the top left. And as you see here, there'll be a CTAK option. And here's a brief video in real time. This is in our office, so I apologize for the lack of stability. Our student was behind me filming. But you can see you click the CTAK uploader, and this is again in real time. It's not sped up in any way. You're already in the patient's topography, so you accept some of the warnings. And then you're going to pick the date of surgery. You do need a 4 to 5 week lead time, whether the patient had LASIK or PRK, which surgeon in your practice is going to be doing the procedure. And then you click Upload Scan, and it really is that easy. So within that period of time, the scan is then uploaded to CorneaGen, and a plan will be then provided for you for the best CTAK inlay measurements to make the cornea a more regular shape. Now, a couple of things about using the CTAK uploader or getting your corneal topography. So you do need iris imaging. So you need an iris camera. You need a Pentacam that has an iris camera to capture that image as part of what is uploaded in the CTAK software. And also, you want to make sure that you aren't capturing a patient in that iris image in any sort of active blink. So some of the warnings, the quality control warnings are okay. You don't have to have a okay on every keratoconus patient. As we all know, when we take Pentacam images, really any tomography or topography images on irregular corneas, as you get to more severe cases, it becomes harder and harder to get that okay quality score on your image. And that's fine. You don't have to have an okay on every patient. But one of the things you do have to be mindful of is looking at the iris image in particular and trying to just make sure that you are getting a good exposure of the pupil and the iris to know that you have an adequate scan. Past that, you could see that really anybody in your office, a surgical scheduler, technician who knows how to operate the CTAK uploader would really be able to upload the scans for you. So what does the surgical plan look like once you've uploaded those scans? So the key here is at the end of the day, the surgeon is making the final selection. So the plan is a recommended plan, but as always with any surgical procedure, clinical correlation is always very important. And so if at any point a surgeon feels like modifications need to be made to the plan, they will do so, and those will be made to the inlay. Or if there are any questions about the plan, you can always relay that to CorneaGen. But just to go over some of the parameters within the plan. So one of the parameters, and these are the alternatives that are presented in the surgical plan, is creating a thinner or a thicker inlay. And in general, like most surgical procedures, you're probably going to start with the recommended plan, use the recommended parameters for your first cases, and then over time, you may develop your own nomogram for certain parameters that you like to adjust based on different factors that each patient might have. So one of those factors that does come up is the thickness, because CTAK is designed to try to recommend a thickness that's going to create a flattening to create the most regular shape that it can in the cornea. What it is not designed to do as of now is really to take refraction into account in any way. So one of the examples of cases where I might go with a thicker inlay would be a case of a high myopic keratoconic patient. So a lot of our patients are myopic in an autorefractor, but not truly myopic. But if you have a truly myopic keratoconic patient and you want to try to get more refractive effect, for example, so you want to get actually more flattening than just getting a regular shape in the cornea, you might choose in a case like that to increase the thickness parameter and try to induce more flattening. One of the places that we recommend reducing the flattening is in some of the ectasia patients. So, and we'll go over that a little bit later tonight, but in ectasia patients after LASIK, where you need to navigate placing this inlay underneath the LASIK flap, you can usually go with a thinner inlay, because also anecdotally in the patients, at least that I've placed the CTAK inlay in, we tend to get more flattening even with the thinner inlays in those patients, likely because their corneas are already thinner and possibly because their corneas are actually biomechanically somewhat weaker. So again, the thickness parameter has some places where you might want to adjust it. Some of the future software upgrades are going to account for at least the ectasia effect automatically. But for now, those are things to consider. One of the other parameters that you can adjust is the inner diameter. So the inner diameter can be at 4, 4.5, and soon to be 5 millimeters. And so you can widen or make more narrow your inner diameter of the inlay. I would say for now, most surgeons don't make many adjustments to the inner diameter. The inner diameter is based on the algorithm that was created and based on the topography that you upload from the Pentacam. But you certainly can adjust it if you feel that's necessary for any reason. And on the second page, you're provided with placement instructions. So these are the instructions of where to place the CTAK inlay relative to the center of the pupil, as well as showing you where the segment, where the inlay edges should be. So that's another parameter which you can adjust on your own. So you could lengthen or shorten an inlay. But once again, we don't see that parameter adjusted very much in most cases by surgeons, since most of the algorithm that was created is already accounting for that. So diving into the procedure itself, once you've uploaded your tomography, once you have gotten the surgical plan and you've approved it, the CTAK tissue will be sent within a month, and then you're ready to do the CTAK procedure. So the steps of doing the procedure is you need to mark the edges of the inlay. I do this at the slit lamp where I place the edges on each axis with the patient sitting up. And then you can mark the center of the pupil. I do place one mark usually at the slit lamp, and then mark it again when they lie down underneath the microscope. Really, the marking, and we're going to go over this in more detail in just a bit, you're going to mark the inferior and temporal distance from the center of the pupil. You then encompass that mark with an optical zone marker based on the inner diameter of the inlay. You're then going to use your femto laser to create the channel, and finally insert the inlay and smooth the inlay into position. So Dr. Gelles, Dr. Hirsch, and myself created, along with Corza, a set of surgical instruments to help facilitate the CTAK procedure. Some of the instruments to highlight here are the markers. So the markers go in 1/4 millimeter steps. There's really no calipers that go in that fine of a step, and they actually range anywhere from 1 millimeter to about 4 millimeters. We primarily right now are using anywhere from 2 to about 2.75 millimeters for most of the marking, but it's very important to use these markers to get an accurate placement of your optical zone marker. There's then an optical zone marker which spans from 3.5 to 5 millimeters, again based on the inner diameter of your inlay. The CTAK dissectors are very important. So one of the things with synthetic segments and femtosecond channels is you're able to dissect those channels primarily with the segment itself. With corneal tissue, with CTAK tissue, you cannot do that. So you do need to dissect these channels fully before placing the inlay, and these dissectors will help you do that. If you have Intax dissectors from the past, those will work to dissect a channel as well. The CTAK forceps are designed to hold the CTAK inlay, but they're also really designed in the curvature to follow the curvature of the channel that you create. So it really facilitates placing and pushing the inlay through the channel into position. The manipulator helps bring the tissue through on the other end, and finally an applanator to smooth the cornea, and we'll see all of these tonight in video. So again, the marking is really critical because the marking is how you are going to decenter your femtosecond laser to apply the channel cut. And what we are used to as refractive surgeons and anybody who has used a femtosecond laser for refractive or cataract surgery, you're used to really aligning everything to the pupil. The pupil tends to be your centration point. But in CTAK placement, the pupil is not your centration point. And so you really need to follow your marker. And one of the things that you need to be comfortable with is actually fairly aggressively marking the cornea with your violet mark. So when you take the optical zone marker, we're also used to with femtosecond lasers trying to actually, if you're going to mark the cornea at all, trying to mark it very lightly so that it doesn't disturb any of the cuts. But the truth is that your mark is not going to be in the area that the laser is going to be cutting. So you really actually want to be very aggressive about your marking so that when you applanate the cornea with the laser, you are able to easily see your mark and decenter appropriately. So again, I usually place these marks at the slit lamp, the 2 axis marks, and then mark the temporal and inferior areas underneath the microscope relative to the center of the pupil. You can also do this with a toric marker, the way you would for toric IOLs. There are a whole host of ways of doing that. You can do that however you choose. So here is one of our cases. So again, we're now see that violet mark. We're decentering our channel to the violet mark, and then we can start the cut from the laser. This is the Z8 making the cut, so it has the ability to cut channels that are less than 360 degrees to the specifications of your CTAK inlay, and also to create 2 incisions on both ends. Most lasers will cut a 360 degree channel, which is fine. You are able to place CTAK inlays in position with a 360 degree channel. So here is the IFS laser from Johnson & Johnson, which I used also to do CTAK. And you can see here the violet mark is much more decentered. So I highlighted it here so that you can see. But when you applanate the cornea, you can really start to think, well, I'm moving too far. This is really very far from the pupil. Am I in the right place? So you really have to learn to trust those marks, because those are where you should be cutting your channel. And I can tell you, anytime that I have erred towards the pupil and not towards my mark, I have regretted it because the mark is in the right place. So now you can see this is a much more decentered channel made 360 degrees, but that is exactly where it should be for accurate CTAK placement. So then once you have created the channel, you need to prepare the CTAK inlay. So the CTAK inlay comes in a vial, very similar to like an ICL vial or contact lens vials. Now this is a very small inlay, which is an albumin solution. So you'll be provided with this strainer, which really does help. You can pour the albumin solution into the strainer, try to release that solution, and it really does help catch the inlay so that you're not kind of searching for it once you pour out the albumin. And you really don't want to throw anything out until you find the inlay, because I found it on that gray cap on the side. This is a case where, and it happens a lot, where the inlay does not come out on the first pour. So I take a Wexel, I can find the inlay inside the vial, and then I gently bring the inlay out. But you can see it's really, really small in this very large vial. So the strainer can be very, very helpful to then hold it for you for the case. Now, one other thing you do want to do is you do want to wash the inlay pretty copiously with BSS. You do want to try to wash off all of the albumin solution, and then the inlay is ready for placement. And finally, we get to the actual procedure. So again, this is us marking the cornea. So we've now placed the temporal and the inferior mark. We have marked the cornea. This is placing the ring from the Z8 laser. It's a 10mm ring, so you get good exposure. You can really move it around to decenter. And then we start dissecting the channels. Now you can use a LASIK dissector to dissect the channels. There's also a CTAK spatula available from Corza. But these channels are not as deep as Intex channels, so you don't have to really dive down deep into the cornea you don't have to dive down deep in the cornea to open them. You can open them, they're only 200 microns deep, and then you place the inlay into position. You can push it with the CTAK forceps, and then actually you can manipulate it a little bit by pulling it with the manipulator into position. Now, one of the nice things, and then finally you smooth it out. Now, one of the nice things about the CTAK inlay is that it does not have to be dehydrated. So the CTAK inlay, because of the gamma irradiation process, it does have structural integrity to it. So you are able to push it and pull it into position right away. You don't have to wait for it to dehydrate to use it in the procedure. It does make it very, very convenient to use. Now, the nice thing about CTAK, so one of the things about CTAK is it is customized for each patient. So some patients can get a short inlay, as short as 150 or 160 degrees, and other patients may get an inlay that's as long as 330 degrees. So we have to be able to place either a short or a long inlay into position. And because CTAK is made out of corneal tissue, it has a lot of flexibility to it. So it does give us also flexibility in how we go about doing the procedure and how we go about handling different circumstances. So for long inlays, you can certainly place those inlays into position in one piece, and I've done that just fine. But you can also cut the inlay in half. So if you want to make the procedure more straightforward for yourself, especially early on when you're learning how to use the instruments and get into position, you can take a 330-degree inlay, you can cut it into two, and you know where your edges are from where you mark, so you know where you want to align the first portion of the inlay. And then you can place the second one into position. Again, it does glide through the channel, so you can push it into position. And as you do that, you just need the two inlays, the two segments of the inlay to meet. And this works just the same as having one long 330-degree inlay. So the nice thing when you're working with corneal tissue is that you have other options of how you can go about doing the procedure and still get the same results. Another advantage to working with an inlay that's made out of corneal tissue is that you can make some adjustments to it. So even with the software, even with the plans, there are certain cases where you might want to adjust the inlay. So this was a case of a 25-year-old that I placed a CTAK inlay into position. And you can see that pre-op he was 20/70 uncorrected. His glasses correction was 20/30. With a high astigmatic and hyperopic correction. When I placed the CTAK inlay, his correction in terms of his refraction was slightly better, but actually his vision, his uncorrected vision was slightly worse, and his spectacle correction was slightly worse as well. So when I looked at his topography at 1 month, I could see that actually I had over flattened his cornea nasally. So if you look at the nasal position, you'll see that we flattened from about 37.1 diopters to about 32.5 diopters. So even though we flattened his whole cornea, even though we made the cone itself flatter, we also flattened the flat portion of his cornea. And so the irregularity is actually still there and maybe even slightly worse. So one option, of course, is to remove the inlay, but I thought maybe we could fix this. And a synthetic inlay, this would be very, very hard to fix because it only comes in its fixed sizing. But in this case, I reopened the channel. I do place some BSS both above and below the inlay just to make sure it separates from the patient's cornea. I use the CTAK dissectors to dissect the top and the bottom, and then I take the manipulator and I can bring the inlay out. And you can see here I marked the edge nasally where I thought I wanted the inlay to end up, so it wasn't quite as long and quite as nasal as it was before. So what I do is I pull out the inlay a little bit past that mark. I then cut the inlay with a Westcott scissors, and I then reposition the inlay back into position so that it would line up with our nasal mark. And now you can see that just by adjusting the sizing of the inlay, the flat area is now basically unchanged. So before he did any CTAK surgery, it was 37.1 diopters, and now it's 36.9 diopters. And yet we've been able to maintain and even enhance somewhat the flattening around the cone. And now we're getting more of the results that we would expect. So his uncorrected vision improved from 2070 to 2050. His spectacle correction improved from 2030 to 2020 with improvement in his manifest refraction as well. So you can see here in the difference map what we accomplished by adjusting the inlay and making it a bit shorter. We steepened nasally back to its natural state, and we actually increased some of the flattening temporally. Here's another case of a 19-year-old male who had had cross-linking done. He was functionally monocular. His right eye had trauma as a child, so he relied exclusively on his left eye, where he had very advanced keratoconus. Now, he was a college student and really had difficulty wearing his scleral lenses throughout the entire day and night. And really, he couldn't function without his scleral lenses. You can see why. His glasses correction is 20/70, and he has a high myopic astigmatic correction. So this is somebody that we really see very commonly with keratoconus, with more advanced keratoconus. He's young. He really demands a high level of vision, but he can't get that in any option besides a scleral lens. And for this patient, his only other option is really corneal transplant. And in a 19-year-old, someone who's functionally monocular, we would really like to avoid a corneal transplant at all costs. So for the most part, we would tell this patient that they have to sort of use their scleral lens as much as they can, but also know in the back of our head that someone at this age that's already overwearing their lens, that's already having some problems with the scleral lens, is likely not going to be able to wear this lens over the long haul. They're not going to be able, as they get into their 30s and 40s, the only problem is only going to get worse. So this is a place where CTAK really shines because we can place a CTAK inlay. We can create a tremendous amount of central flattening. You can see here how much flattening we were able to create, maximum almost 18 diopters. We create a very regular central astigmatism, which is one of the things I always like to point out about CTAK, is that when you keep doing it and you keep looking at these post-op images, what you will see is this regular central astigmatism that you can continue to create, whether you're in a mild, moderate, or severe case. And now after doing that, his uncorrected vision was actually 20/50. His correction in glasses is 20/30 with a much more manageable prescription. So Dr. Gelly still fit him with a scleral lens. He still wears a scleral lens for the most of the day, but he is able to take that lens out and still be functional. And this is a major improvement for quality of life. It's something that we don't think about enough with our keratoconus patients, but if we can reduce their contact lens wear to 8 to 10 hours a day and give them a functional life when they take their lens out, that is incredibly meaningful for these patients. And it's a really important group of patients to not forget about when you're offering surgical procedures. And CTAK really shines for these patients and correcting them to the point that they can feel more functional without their scleral lens. So Dr. Gillies could talk more about this actually than I could, but one of the advantages of CTAK is really the contact lens fit afterwards. So one of the challenges that we've always seen with INTACs and why in the ophthalmology community, I can speak on our behalf, we would do INTACs and we would see some improvement for some patients, and we would think that was great. They were better off than they were before. But then in the optometry community, there'd be more frustration because they weren't good enough. They still needed the scleral lenses, exactly the case we just talked about. But now their scleral lens fit is much more challenging. Patients are complaining about the comfort of their lenses. And then we even start seeing things where because of erosion around the INTACs, because of the way that the lens can rub against those areas, that we actually create more of a problem with the INTAC segment and in combination with contact lenses, then we've really helped these patients. And you can see why the CTAK inlay really doesn't have that same problem. So these are high resolution OCT images on the new up and coming Pentacam corneal OCT. It's not yet FDA approved. But they really create the most high resolution and images that I have ever seen in the cornea. We are learning new things about the cornea every day as we take these images. But what you can see is that the peripheral profile of the cornea with CTAK really remains relatively unchanged. So because it's a wider inlay, and when you look into the periphery where the scleral lens, where contact lenses tend to sit or need to clear, the periphery of the cornea is actually mostly smooth and unchanged, which unlike INTACs, which actually creates almost a bump in the cornea, and that can be the challenging part to fit. So if you think these are great images and zoomed in and looking right at that peripheral area, you can really see it on the zoomed in images that you can get with this up and coming OCT. And you can really see that bump area right over the INTACs. That is the challenging, that small kind of bump is the challenging part to fit with a very, very thin epithelium right over the top. And then if you look at the CTAK, you can see then in the periphery, it's very, very smooth. And you can see that the epithelium is actually relatively normal. And then inside of the inlay, you can see that's actually a thickening of the epithelium that you're looking at, right where kind of the inlay, you see that kind of bend down in the corneal stroma. There's a thickening of the epithelium. And that's actually, you're actually looking at really the action point of a CTAK inlay, right where the corneal is lifted and the corneal flattening takes place right inside. That's where you get all of the effect from the CTAK inlay. And then the epithelial hypertrophy and the remodeling around it is really what gives you its full refractive effect. So these images really show you both why contact lens fitting is challenging with INTACs, but also why the CTAK inlay is so powerful. So what we have done for patients is we have actually removed some of their INTACs segments, and we have replaced them with CTAK inlays. So this was a patient of mine who had a transplant in their left eye and INTACs in their right eye. And when they started, you could see that their right eye is still counting fingers, their vision's 2400, and their refraction is myopic, very anisometropic. And you can see that when you look at why this patient isn't really happy with their INTACs, actually their vision was worse after INTACs placement than it was even beforehand. So we really haven't accomplished anything with the INTAC segment. So we took his INTACs segment out and we replaced it with a CTAK inlay. One of the things that you do have to just navigate, and anybody starting out with CTAK really should reach out to one of us or to CorneaGen if you're planning on doing a case where you're going to remove a CTAK segment and place a, you're going to remove an intact segment and place a CTAK inlay to replace it. One of the things you have to navigate is just your incisions, because what's going to build up is you have your initial incision for the intact placement, which I highlighted here in orange. You're then going to have your incision that you place to remove your intact segment, that's in green. And then now you're going to want to make more incisions to place your CTAK inlay. So all of a sudden you're kind of building incision on incision. And one of the things you can't do is you can't place a CTAK through these old incisions. So what I like to do is I like to actually send the topography before I take out the intact segment and get a sense of what the surgical plan that's being proposed of the CTAK inlay would be. And that gives me a sense of where the incision already is. It also allows me to plan where I want to put the CTAK, where I want to put the incision to remove the intact segment, trying to keep it kind of as far away from the intacts, from where the edge of the CTAK inlay would be. And then finally, where you're going to position your CTAK incisions to give you the most room to maneuver around and get the longest possible inlay that you can get in relative to the ideal surgical plan. So these cases can be done. These patients actually have been very, very happy, but you do need a little bit of extra thought and planning before moving forward. And so we've done now more than these 3 cases, but you can see in these 3 cases where after intacts, spectacle correction did not improve as much as patients had desired. In all cases, the CTAK inlay provided much more spectacle correction. So patients really noticed that difference when they were exchanged from intacts to a CTAK inlay. And one of the other scenarios to really highlight also is ectasia after LASIK. So as Dr. Gelles pointed out, these are not the patients that you want to start with. So one of the things I always like to tell people starting out is you want to get a comfort level of how to manipulate the inlay inside the channel, how to make the channel cuts. You want to get comfortable using the instruments, getting a feel for how you place the CTAK with the CTAK forceps and how you will maneuver that CTAK around within the channel. You really do want to be comfortable with those things before you start doing ectasia cases because ectasia cases do add a level of complexity that you do have to account for. So one of the main thing is you're accounting for, of course, the LASIK flap. We do recommend at a minimum starting by placing the channel slightly deeper than we would for a traditional CTAK inlay in keratoconus. So we start at saying to place those inlays about 250 microns deep, and some surgeons have preferred going 275 or even 300, although you do have to be careful because these corneas are thinner. We also, as I talked about before, recommend that you do consider using a thinner inlay. So I do think there is more flattening that you get even from the thinner inlay in these cases. So again, at a minimum, reduce the inlay by 50 microns. I would even consider reducing in many cases by 100 microns the thickness of the inlay. And then you really just want to be very careful as you're doing the surgery to go slowly and make sure you're doing the surgery in the right planes. So I have done it where I will start to dissect and you are clearly in the plane of the LASIK flap. You know that because as you dissect, you start to move centrally and you don't hit a hard stop. You start to keep going and then your heart stops for a second, but you realize that you haven't really done anything terrible. You can remove your instrument and the LASIK flap is usually just fine. And then you just need to go deeper with your dissector and make sure that when you go deeper, you do hit that hard stop. So when I do these procedures, both with the CTAK spatula, but also with the CTAK dissectors, I will constantly be kind of moving them centrally and making sure that I am hitting a hard stop. And anytime you're hitting that stop, you do know that you are then in the proper plane and in the channel. Now, one of the things that can be very helpful with planning for CTAK for ectasia after LASIK is OCT imaging. So again, these are the OCT images from the soon to becoming Pentacam OCT. And again, these are just some of the clearest corneal images you will see, to the point that you can really fairly now much more easily identify where the LASIK flap is, and really start to get a sense of where the depth of the flap is. So this is a LASIK flap that's done with a femtosecond laser. And so it's a more anterior flap, about 110 microns deep, which again gives us a sense of how much room do we have underneath to work. On the flip side, here is a patient who has a microkeratome flap. And so those flaps are much thicker. We're looking at a flap that was cut about 200 microns deep. And clearly that's going to create a very, very different situation when you're trying to navigate where to place your channel, or if you even want to approach placing a channel in one of these patients. So as you have those deeper flaps, it is really important to identify that plane and decide how deep you're going to place your CTAK channel. If you place this channel 250 microns deep, you're only about 50 micron difference between the LASIK plane and the CTAK channel, which can be very difficult to navigate. Again, I just use this as an opportunity to highlight some of the things that we're really able to see with this OCT. You can see that here we can even identify exactly where the side cut is from the LASIK flap itself. These are really just images that we had really never seen. So now that you know kind of the depth of the LASIK flap, the important thing is to try to then navigate the thickness of the ectatic cornea. So you have to remember, this is a cornea that's already had an excimer ablation to it, usually a myopic ablation centrally. So it is already inherently thin centrally, and now even thinner over the area of the cone. So in this case, if you look at this ectasia case, at least at its thinnest point, somewhere around 350 microns, and that we're usually not so concerned about because we're not placing the CTAK inlay right over the thinnest point. We're actually placing it around the thinnest point. So we're more concerned about the depth in the area we're placing it. But again, if you have a wider ablation zone now, you are getting closer in a 6.5 millimeter ablation zone, let's say, to the actual area where the CTAK channel is going to be placed. So as you start to do your measurements on OCT, you really do account for the flap, in this case, a flap that's about 120 microns deep. And then you really want to look more paracentrally, how deep is the cornea where you are going to create your channel, and try to decide where you want to create it, 250, 275, or maybe 300 microns deep. But as you go deeper in the cornea, you have to be careful that you're actually not going too deep. So one of the nice things is if you do have OCT capability in your femtosecond laser, then you are able to actually take an OCT, and this is an OCT that we took of an ectasia patient. This is a case where I did originally want to set the inlay deeper to get below a deeper flap, but you can see here by setting it at about 300 microns, we're really getting close to the endothelium. And so you really have to navigate, this is probably now too deep, and we need to actually raise that channel up a little bit to maybe about 275 or 270 to try to find that sweet spot of placement. So the Z8 is one of the lasers that has that OCT capability, which is really nice to be able to use intra-op before placing and before making your femtosecond cut. And finally, not every CTAK is going to be perfect. So I have had my share of difficulty placing CTAKs occasionally. And you can sometimes get a channel tear. Now, fortunately, with the CTAK instruments now being designed to follow the curvature of the channel, we've really been able to avoid channel tears. They're pretty infrequent now. But again, because you're working with corneal tissue, not every channel tear needs to be aborted. You can, if you have a small tear that's kind of by the edge of the incision, you can still place your CTAK inlay and usually just place a suture in that area and these patients do very well. I did have one case where I felt that the tear was too large and the CTAK inlay could not be placed, and we did abort the case, but fortunately we were able to repair that, and the patient was able to get back in their scleral lenses with no change in their lens corrected vision. So most of these, if you get them, they're very small. You're able to navigate them and you can still place a CTAK inlay, and these patients do very, very well. Very rarely do you have to abort these procedures. So hopefully that gave you a nice tour through the CTAK ecosystem. Again, it is this customized approach that takes your patient's corneal topography on the Pentacam and then allows that to be cut into specific parameters and then placed at a specific location, which is all provided for you, which really allows you to embrace this procedure and really provide it for your keratoconus patients, whether they be mild, moderate, or severe. So thank you, everyone, for your attention tonight, and we'll turn it over for any questions.
Wonderful. Thank you both for taking the time to share your expertise this evening and for providing such a comprehensive overview from patient candidacy to execution and then follow-up as well. That was fantastic. We do have quite a few questions here, both sent in during the presentation and beforehand, so we'll see if we can get through just a handful here. The first question here, and feel free to take these in any order you prefer, you're both welcome to jump in, is how do you go about discussing the recovery process from CTAK to your patients?
Sure. So, I mean, I tell patients that the recovery is different for everybody. In terms of discomfort, the discomfort if you're only doing CTAK and not doing any kind of cross-linking with it is going to be very minimal. I mean, really, it's just the incision itself just needs to recover, which is going to happen within a few hours. So in terms of discomfort, I do place a bandaged contact lens for one day, but I tell them the discomfort is going to be minimal. The vision correction is different for everybody because CTAK, as we said earlier on, it's not a refractive procedure in the sense that it can predict that you're going to have no refraction when it's all done. So we actually have some of our most severe patients who notice the most change on day one because they're seeing a huge refractive shift. As Dr. Gilly showed you, the original data we published on was more severe patients. And so they can really see this huge change in their uncorrected vision. And that's kind of that LASIK-like effect we talk about where day one, they're seeing so much better. And there's a little fluctuation to it, but generally that stays pretty consistent. For your more mild and moderate patients, I tell them that you may notice some improvement early on, but you really have to wait 4 to 6 weeks for us to start checking your prescription again. Because it's not really until we check your prescription that we're going to really see all of the improvement that we're looking for in glasses and then eventually contact lenses. There's a little bit of a up and down over the first 1 to 3 months from epithelial remodeling, but there's such a profound flattening effect that you get from the inlay from the beginning that the patients I find don't notice that very much, even though we pick up a little bit of it when we measure that fluctuation along the way. So I tell them give it 4 to 6 weeks and then you'll know a lot more.
Wonderful. Thank you. As a second question here, how does the approach for fitting a contact lens on a CTAK patient differ from the regular process? What does that process look like?
Yeah, so generally in these patients, what we're looking at is the, kind of the postoperative outcome as far as the shape of the cornea. What we find in many of these patients is when their cornea is flattened, or rather their curvature is repaired to such a level that they are with CTAK, it opens up the options for them. So many of the patients who maybe previously would have only been a candidate for a scleral lens, many of them actually can be relatively well corrected with a soft contact lens. So I would never tell a patient that that's the purpose of doing the procedure, but it is a very nice benefit to it afterwards when, if they had problems with their contact lenses before or were showing complications from overwear. they can do very well with other options at that point, and it kind of opens things up. That being said, generally, I'll start a contact lens fitting generally around the 4-week mark post-operatively. That'll give us an opportunity to get most of the healing done that's important, and then kind of fit our contact lens from there. If they do well with a soft lens, the nice thing with that is I generally will order a standard soft lens for them, and then as they're kind of going through the healing and the epithelial remodeling over time, I'll alter that every few months so that we have a better result. In those individuals who are in a scleral lens or other sorts of contact lenses, the nice thing with that is, you're going to be in the fitting process. There's virtually no lens where you're going to be one and done on every single case. So, typically, it puts them into the fitting process. And if you look at the time between lenses, you're typically going to be wrapping up, several weeks down the line. So, at that point, they've kind of settled in, and your options really expand, though. I think the thing that's most important, and Dr. Greenstein really touched on this at the end there, is, this is all about the comprehensive vision of the patient, right? The ability to get them more functional vision and give them more options for correction. It's so frequent that we hear from patients that, hey, I have such a difficult time when I'm not wearing my contact lens, and I'd love to be able to take my contact lens out once I get home at night, but I can't function without it, so I have to wear it until I go to bed. And this is just hugely beneficial to their quality of life. They're so much happier. But as far as the contact lenses are concerned, start at about 4 weeks. You can evaluate based on, kind of response. I like to check and see if a soft lens is an option. If it is, great, we go that direction. If it's not, we still need to be in a scleral lens. Great, we stay in a scleral lens. And sometimes you don't really have to alter your scleral lens fit. Sometimes if the predicate lens was fitting very well preoperatively, sometimes you can just put that lens on the eye, look at it and say, okay, how much of an adjustment do I really need to make to the parameters of the lens to adjust sagittal depth or other things like that? You'll definitely have an over-refraction effect in some cases. But generally, it's not a huge amount of change that you're inducing to the contact lens fit itself. So it's kind of nice that way, because obviously scleral lenses avoid the cornea. So, you're jumping over, doesn't really matter what's happening underneath. So
wonderful. Thank you both. And with that, we will wrap things up for the night. Thank you both again, Dr. Gillies, Dr. Greenstein, for taking the time to share your expertise with us this evening. We really appreciate it. To everyone listening, thank you for joining tonight, and thank you from all of us at Oculus. I hope you have a great rest of the night.
Thank you for inviting us, and have a good night.
Thank you.
Thank you. Thank you.